About the endocrine metabolism, we know that the endocrine gland, the hormone is produced, and then from there, this hormone goes to the site of action where it can be either inactivated or activated. So disorders which are there, which are associated with decreased activation, will result in deficiency, while those associated with inactivation will result in a problem of excess. So you can have problems in both regards depending upon the balance which is there in that regards. One of the most classic examples that I was discussing are the steroid hormones and the androgens. So testosterone basically we know is a pro-hormone. The testosterone is converted via the 5-alpha reductase to dihydrotestosterone, which has got a higher potency as compared to testosterone. Now DHT does not have a greater binding affinity. The affinity is pretty much same for testosterone and DHT, but the duration till which the DHT acts is much more. So DHT will have a more impact at the same concentration in that regards. And that's particularly relevant when we talk about 5-alpha reductase deficiency. So why is it, Alapan, that in 5-alpha reductase deficiency, the internal organs, the prostatic development, the Wolffian maturation, they're all normal, but the external structures are defective.
The internal structures which the hormone which determine the internal structure what would be is the AMH. So
AMH is for the Mullerian structure, not for the Wolffian structure. So what I'm trying to say is that the prostate, the prostatic urethra, the other development is normal.
Because the testosterone concentration is high. So
yes. So if you have a very high level of testosterone, you don't need a DHT to act. So because here the testosterone is produced by the testis, acts immediately, and therefore all these structures are growing. But for the peripheral action on the penile area, you would need the blood to reach there, and you need a much higher level. That is why you have a discrepancy between the internal and external structures in the setting of 5-alpha reductase deficiency. Now, once you enter into puberty and your hormone levels increase, you will also have virilization which happens in that regards in those organs in that perspective. Now, testosterone can also be aromatized to estradiol. Of course, we know that this can happen in both males and females. And this is an important mechanism by which the bone health and the epiphyseal fusion is regulated from that perspective. And that is why there is a theoretical possibility of using aromatase inhibitors in terms of delaying the pubertal fusion and increasing the duration of growth, particularly in boys. Now, aromatase is also expressed in the adipocyte. And that really explains why we have a higher chance of gynecomastia in obese boys and precocious puberty in obese girls in that regards. So we have a 10-year-old girl with clitoral enlargement, Dhwani, who has a phallic length of 2.2 centimeters, has bilateral gonads. So the parents have now come to you with that she's a normally raised girl as a female. Now she comes to you that there are changes which are happening, but you identify that they are bilateral gonads. So what do you think is happening here, and what would you do further from here? Yeah.
Knowing that this is a 10-year-old child, the chance of salt wasting looks less likely.
Yeah.
So we would like to go.
So what are the conditions which tend to virilize at puberty? Yeah. Yes. So conditions wherein you have more pubertal production of testosterone, you will have this virilization happening. So now the next step, of course, will be to look at the Mullerian structure, which in this case was absent. And as you said, this was a XY karyotype. Now, how will you know this is 17 beta HSD versus partial AIS versus 5-alpha reductase?
If the LH levels are pubertal, we would like to do first exercise-related testing levels. And if it is already in the pubertal range, we can do basal LH.
Yes. So I think the estimation of testosterone would be the first thing which will give you a clue in that regards. And you found that the testosterone level is on the higher side. And on top of that, you found that the DHT testosterone is there, but it is not getting converted into dihydrotestosterone, indicating a diagnosis of a 5-alpha reductase deficiency. Now, how will you manage this individual?
this child testosterone is there, but it's high concentration, but not converted. So we can go for the local application of this DST gels.
So you can give local DST, but then she's a girl. So you have to first of all think about a lot of other issues. You have to think about that. How would you rear the girl? Would you like to rear the child as a girl or as a boy?
Social issues will be there. But I think considering this one, I would like to rear as a male.
So in 5-alpha reductase deficiency, of course, during the fetal period, the testosterone will be high and they would have virilized the brain, so to speak. So the ideal scenario would be to rear as male because there is a very, very high likelihood of gender dysphoria, which will happen if you rear that child as a female. So this becomes important as a metabolism defect in that regards. Another very interesting metabolic defect. Yeah, Alapan. Day 3-old child with DSD, Prader 4, no palpable gonads. Now, this is a different scenario. There you had a girl who had palpable gonads. This is again a scenario where you have a DSD, but there are no palpable gonads here. So what is the condition you're thinking of, type of condition? Yeah, and it was a XX, 17 OHP is 25, labeled as congenital adrenal hyperplasia. There is no salt wasting. And as usual, people will say that CAH is the most common cause of XX-DST, so hydrocortisone was started. But on follow-up, gradually the hydrocortisone requirement came down and the treating physician was able to stop the hydrocortisone. And despite that, the 17 OHP is normal. So beyond CAH, 21-hydroxylase, what are the other possibilities you will think of in this apparent individual with XX-DST?
Present like this is 11-hydroxylase deficiency.
Okay.
Another is 3-beta present like this.
3-beta and 11 and 17 OHP will be mildly elevated, but they would require hydrocortisone treatment in some perspective. So what is the other group of metabolic problem, as I said? So you think beyond the CAH part. So aromatase will be a very, very important differential here. And when we really inquired, we found that there was a maternal virilization. Now, maternal virilization typically happens in aromatase deficiency, POR deficiency, or maternal tumors, which are causing that. But in that scenario, you will not have a postnatal hyperandrogenism because that would be restricted for the time by the time mother's testosterone was so high that the placenta was saturated. It allowed some of these androgens to go by. That will be like a luteoma of pregnancy or some sort of a malignant tumor, which will be there in that regards. Now, one very, very important mechanism by which thyroid function in the body is regulated is via the balance between the thyroid functions. And we know that T4, again, like testosterone, is a prohormone. So this T4 can either be activated using the monodehydrogenase activity 1 into T3, or it could be inactivated via the monodehydrogenase 3 activity into reverse T3. And whenever the body wants more thyroid, it will go more towards the monodehydrogenase 1, while if it wants to deactivate, it will go more towards the monodehydrogenase 3. And this balance plays an important role. And the classical example we know is a fetal state, which is basically an inherent hypothyroid state. So fetus, you have got a greater exposure as far as MDI3 activity is concerned, more of reverse T3, and T3 levels are on the lower side from that regards. So 10-day-old boy, period of gestation is around 28 weeks, has been admitted, is on phototherapy and ventilation, blood sugar is normal, you have a low level of FT4 and a TSH is normal. So this is central hypothyroidism. Yeah. So you will think that this could be a non-thyroidal illness. Anything else considering a very, very premature gestation in this scenario as well? Yeah, so this could also be a transient hypothyroxanemia of prematurity. So it is because of sickness, but also because the child has come out early. As we have seen already that the thyroid hormone levels will go up gradually. It will the time when it will be low in that regard. Then the child is also on dopamine. So illness, dopamine, and prematurity can all explain a low level of T4 despite a normal level of TSH. So what we are seeing essentially here is that you have got the levels which are you have delivered out here. That's why the levels are not high enough as far as T4 and T3 is concerned. 11-year-old girl with pneumonia, FT4 is low, TSH is again on the lower side. So again, do you think this is do you need an MRI to look for central hypothyroidism, cortisol? What will you do? So this again is a metabolic issue which may happen because of illness. So you said you wanted to do a cortisol level. If your cortisol is normal, what do you think? So why are you looking at cortisol? So why is the TSH low in non-thyroidal illness? It is because
the brain, there is conversion of the DiO2 activity is more.
And you talked about cortisol as well. So high cortisol suppresses TSH. So if your cortisol is high, that will be appropriate for a stress. Then you can say, okay, this is a non-thyroidal illness. If your cortisol is low, you're thinking of a multiple pituitary hormone deficiency as a possibility in that regard. So repeat after 3 weeks, you find that this has gone into a hypothyroid picture. So metabolism issues are important in the prematurity as well as illness in that regards. Another steroid hormone which is heavily regulated at the level of metabolism is vitamin D. We all know that vitamin D is produced under the exposure of sunlight from 7-DHC to cholecalciferol. And then this choline-ergocalciferol are activated via 25-hydroxylase in liver to produce 25-hydroxy vitamin D, which is further activated via 1-alpha-hydroxylase in the kidneys into calcitriol. Now, body also has got mechanisms to shunt away any excess amount of vitamin D. So if you have got too much vitamin D, it will be inactivated into 24-hydroxylase. So there are multiple enzymes which are there, which are regulating vitamin D. As for anything which is very, very important. So what would be the effects of various defects in these activities? So if you have too little 25-hydroxylase, what will be the clinical picture? Okay. Type. So what would be their manifestation? So I'm not talking about 1-hydroxylase. 1-hydroxylase are the one which will really present as a VDDR 1A. They will be the severe forms. What about 25-hydroxylase, these defects?
They will also present with rickets and will respond to the
Why? Because you don't have 25-hydroxylase. How will they respond?
that will be too much for the hydroxylase.
So essentially, you're not giving 25. So this is a scenario in which 25-hydroxylase deficiency is there. High dose will circumvent that process. So whatever 25-hydroxylase is there, you will circumvent that, and then you don't need an activated form. And your vitamin D levels will always be on the lower side. So they will behave like vitamin D deficiency. Your 25 OHD will be low, but they will behave like vitamin D deficiency, but they will respond to a supraphysiological dose of vitamin D when you give. Increased 25-hydroxylase activity, what will it do? And when will that happen? So what conditions are associated with increased 25-hydroxylase? So that is just like a limiting response. But in what conditions you have got more 25-hydroxylase, Dhwani? It will cause rickets. It will cause hypocalcemia. It can cause osteomalacia. All those things can happen. I'm saying increased 25-hydroxylase activity. This one.
In present, like how?
Yeah, how will it present?
There will be much more 25-hydroxylase.
So you will have hypercalcemic process will be there in that regards. Now, what about 24-hydroxylase? If you have got too much 24-hydroxylase, how will it present? So your 24-hydroxylase is there, so you are losing out on vitamin D. And what are the classical example of that in that scenario? So various antiepileptic drugs like phenytoin, phenobarbital will present like osteomalacia, rickets, and you will have a scenario like that. Deficiency of 24-hydroxylase will present with?
Excess of vitamin D. Like,
So you will have hypercalcemia, and the classical example is idiopathic hypercalcemia of infancy. So in that scenario, you will not have too much vitamin D toxicity without supplementation. But when somebody has supplemented, then they will develop rapid onset polyuria and constipation, irritability, features of hypercalcemia. And 1-alpha hydroxylase we already discussed about in that regards. So 2-year-old boy with rickets, no response to vitamin D, calcium is on the lower side, phosphorus is low, ALP is high. So what are we thinking of? Yeah, with low phosphorus. So hypocalcemia. Yes.
vitamin D deficiency is definitely there. But
So you can say
response-
impaired vitamin D defect. You can't, yeah. So vitamin D is not working well. So what next will you do?
the vitamin D and calcium level.
So vitamin D is 120 and your calcitriol is low. So what do you think is happening?
Not converted to calcium to 1-alpha hydroxylase.
So this is the classical case of VDDR type 1A as we discussed. So there's a problem in the 1-alpha hydroxylase. The treatment here would be to give calcitriol. What dose of calcitriol will you give? Physiological or supraphysiological? Or very, very high?
Not very high, but above the physiological dose is required.
Yes. So you need to give at least 5 times the physiological dose. Why? When you treat simple rickets also, you need to give 5 times at least the dose of the initial dose they're talking about. So that's why you need to give a high dose to begin with. Now, many people, what they do is that they say, okay, there's a problem in conversion. So let's give a 1-alpha hydroxylase that should take care of it. No, it will take care of your maintenance dose. But if you want the rickets to heal, you would need to give a dose of around 100 to 150 nanogram per kg per day, which will be like 5 times the normal dose. So this is VDDR1 in that regards. Now, yeah, Dhwani, 1-year-old boy with bone pain, cholecalciferol sachet was given, 1 sachet weekly. Within a week or so, he came to you with abdominal pain and polyuria. So what is the first thing you will think of in somebody who comes to you with irritability, abdominal pain, dehydration, and polyuria in somebody who has received vitamin D? So that will be a very important thing to look at. So now you find that there was a hypercalcemia and you thought that maybe they've given a lot of doses of vitamin D, but mother said, no, we have given only a single dose. So what are you thinking of? Yes. So this is an idiopathic hypercalcemia of infancy. So what's happening is that the child was fine till he was deficient in vitamin D. He was not even having that. So inactivating was actually helping him out. But once you gave a high dose of 60,000, suddenly all of it got stuck there and that causes hypercalcemia. So if you have somebody who develops features of vitamin D excess with limited amount of vitamin D, start thinking of these possibilities in that regard. So this was 24-hydroxylase deficiency. Rickets can happen with that, and anybody can have rickets basically. If you have too much deficiency, you will have rickets. So if you don't have vitamin D, you don't have anything, you don't lose anything, it doesn't mean that you are going to gain that. First, you need to get that amount, then you will have bone formation happening. Now, cortisol we discussed is a very, very interesting compound which is really regulated largely at the level of particular organs. So how do a particular organ decides that this hormone will act at my side or not? What are the various ways you think of?
Binding proteins.
Yes, very good. So you attract the hormone to that side. Number 2, you need to have a receptor there. That is number 2. Number 3, if you have a receptor, you will have the post-receptor pathway. You will have something which can either destroy that particular hormone or activate that hormone. So local metabolism, that becomes important. And 4th mechanism is if you have a transport protein. So if you do not have MCT8, thyroid will not enter the cell. So same thing becomes important from that regards. So cortisol is largely regulated at the level of the local metabolism. And we know that cortisol and cortisone are pretty similar in structure. They all need to be converted using the 11-beta hydroxysteroid dehydrogenase. There are two types. The 11 beta HSD2 is largely working to inactivate cortisol to cortisone, and 11 beta HSD1 is activating cortisone to cortisol at low concentration. And at high concentration, it is also inactivating that from that perspective. So if you have a glucocorticoid responsive tissue, you would like to have more of 11 beta HSD1 to amplify the effect of cortisol. So even if you are deficient, you will get more cortisol effect, which is there. But if there is a mineralocorticoid responsive tissue, you do not want this glucocorticoid to go into the cell and act on the mineralocorticoid receptor. Which has got more affinity to the mineralocorticoid receptor, cortisol or aldosterone? So both have equal. That's why the way by which you have a selectivity of mineralocorticoid to the aldosterone receptor is basically at the level of destruction of cortisol. So now when I'm talking about 11 beta HSD2, which is converting cortisol to cortisone versus 11 beta HSD1, which one will have a higher Kmax compared to that, which will require lower concentration to get active? Why do you want that? Yes, so around 1,000 times. So when you say cortisol, it's like nanomoles per liter. Aldosterone is like picomoles, so it's 1,000 times. So even if you have, let's say, one molecule of cortisol which escapes this 11 beta HSD2, it will go into the cell and overwhelm the mineralocorticoid receptor, causing hypertension, hypokalemia, and alkalosis. So the mechanism is such that if you have 11 beta HSD2, you will not leave a single cortisol there outside, it will be destroyed. If you have low level of cortisol, you are in deficiency, your 11 beta HSD1 will work, okay, I'll now need to convert it to cortisone to cortisol. But when you have very high level, let's say Cushing syndrome, then 11 beta HSD1 will go to the other way. It will destroy that. So this balance becomes extremely important in that regards. Now, we know that growth hormone and thyroxine have an impact as far as cortisol metabolism is concerned. They promote the conversion of cortisol to cortisol. So starting growth hormone or thyroxine in somebody who has got cortisol deficiency may precipitate the adrenal crisis, which you really don't want to do in that regard, and that becomes important from that perspective. So 1-year-old boy with failure to thrive, polyuria, and hypertension has hypokalemic alkalosis. So what does hypokalemic alkalosis with hypertension mean? So there is an increased aldosterone effect. So don't say that aldosterone is excess. It means that the aldosterone effect is more. So now what is the next way? How will you go forward from here? So you can do renin and aldosterone. Okay. So both are undetectable. So as you said, aldosterone is not excess, but the aldosterone effect is there. So what are the term will be?
I think that is not there, but that working as a aldosterone.
So in the absence of aldosterone, you have got more effect. So this could happen in the setting of some other agent acting at the level of aldosterone receptor, which is that is different. Then your aldosterone will be high. If your aldosterone secretion is stimulated, like deoxycorticosterone, DOC, it may be acting on the mineralocorticoid receptor. What else can act on the mineralocorticoid receptor? We just discussed, Abhi. Cortisol. So condition in which you are not inactivating cortisol, it will cause a lot of action. So that is what is known as apparent mineralocorticoid excess. So this is mineralocorticoid excess, but this is apparent because their aldosterone is undetectable. And then you may have a post-receptor mechanism. Forget about aldosterone, forget about its receptor, but the main target site is acting more. So that will be what will be the target site of aldosterone action? What is the major work of aldosterone? Direct impact. What is the major impact of AVP?
That is retention of water.
No, what does it do at a molecular level?
AVP actually stimulates to insert aquaporins on the.
It pushes aquaporin to the membrane. It increases the permeability of the duct to the water. What does aldosterone do? It pushes the
There's a particular inactive channel.
sodium potassium channel. So if your sodium potassium channel becomes hyperactive, whatever the reason is, you will have hypertension, hypokalemic alkalosis. So again, in this scenario, you've got two differentials. Either this is an apparent mineralocorticoid excess or it is a Liddle syndrome. And to distinguish that, you can look at the response to mineralocorticoid antagonist spironolactone. So what you do here is that whether there is a response to spironolactone is there or not, you will know that this is an apparent mineralocorticoid excess. So again, metabolic defect can have a huge impact in terms of the scenario. And in the initial phases when the AME was discovered, people were thinking that a lot of these secondary that normal hypertension that we are talking about, essential hypertension, that is because of this AME activity. But then this has not been proven in that regards. Now, placenta, we discuss a lot, is a very, very important organ in terms of the perinatal endocrinology. First, it is a sieve. It allows some molecules to pass, some to not. So it will allow your TRS to pass, T4 and T3 to pass, antithyroid drug to pass, but TSH will not pass. Then second, it will itself produce some hormones, like it will produce the HCG, which is a very, very important. Then you have got the human mammotropin, somatomammotropin, which will cause insulin resistance. It can also produce the TRH, also can be locally produced, the CGRP, the calcitonin gene-related peptides. So a lot of these products can be produced out here. And very importantly, it has got a lot of enzymes which can regulate the transfer of substances from one part to the other. So I'll focus mainly about metabolism. So we have got 11 beta HSD2, which already we have discussed is inactivator as far as the cortisol to cortisone is concerned in that perspective. The androgens also cannot cross because they've got 17 beta HSD. Now I told you that in scenarios like too much aldosterone production in the androgen production in the mother, in the case of ovarian tumor or luteoma, you may have virilization of the baby. That's basically because you have too much and you have got to above that particular level. Similarly, if you have ectopic Cushing syndrome, why do you have hypertension, hypokalemia, alkalosis, and ectopic Cushing's?
Not suppress the ectopic ACTH production.
So, how does cortisol? Cortisol is going to be killed by the 11 beta HSD2.
The amount of cortisol surpasses the
It is too much. So the levels, once you go above 1000, 1100, it will be too much overwhelm the capacity of 11 beta HSD. Same here, the androgens, if it is in huge amounts, mother is really virilized, you will have overwhelmed the capacity of 17 beta HSD2 and the baby will get virilized in this perspective. Now, similarly, the DHEAS, which is coming from the fetus, and we know that fetal adrenal is like a factory. It's producing DHEAS, which is then being aromatized via the placenta to produce estriol in the mother. And if you have got a sort of a problem in aromatase, the DHEAS will cross them, and that is going to cause virilization in the mother. So that's what you talked about in that aromatase case. Now, Alapan, we have discussed that the hydrocot cannot cross the placenta. You have a 24-year-old lady with pregnancy and now has developed polyuria. She had a child with nephrogenic DI. Before pregnancy, she did not have any impact as far as the polyuria is concerned. But during pregnancy, suddenly she starts having polyuria. What do you think is happening here?
Requirement is high.
Why?
Because it's required by vasopressin from the placenta.
Yes. So there are two types of things. One is that your vasopressinase activity is too much that can cause that. Or you can have a true form of DI which may develop transiently in pregnancy. So what we know that this mother has nephrogenic DI in the baby, so she has to be the carrier. So 50% activity is less already. Now, if out of that your vasopressinase is destroying some of that vasopressin, you will become deficient and you will develop polyuria. She will then be managed with DDAVP. Would DDAVP be effective in this case? Why? So the major advantage of DDAVP is it is vasopressinase resistant. That is why its half-life is good. That is why it will be the agent of choice in that perspective.